Hello, my name is Kelly Cushing, and I'm an IBD specialist at the University of Michigan. Welcome to the IBD School 200 series. In this video, IBD School 227, we will be talking about the recurrence of Crohn's disease after surgery and strategies to prevent recurrence. It is not uncommon for patients with Crohn's disease to need a surgery. More than half of patients with Crohn's disease will require a surgical resection in their lifetime. After surgical resection, a patient's risk for recurrence is assessed, and individualized decisions are made about need for and timing of postoperative therapy. Surgery is typically performed for one of two reasons: to remove the inflamed bowel that has not responded to therapy, or to remove a segment of scarred bowel which is causing obstruction. Typically, patients will have no remaining diseased bowel after surgery. We refer to this as surgically induced remission. Such patients are still at high risk for Crohn's disease recurrence, however. After surgery, a clinician will make a decision as to whether or not the patient is high risk, meaning the patient will need therapy right after their surgery, or if they can be monitored for recurrence. There are three main risk factors for recurrence. The first is penetrating disease, meaning that the patient had previous inflammation extending through the intestinal wall, such as occurs with a fistula or an abscess. The second risk factor is smoking. And the third risk factor is having prior surgical resections. These risk factors help inform clinicians as to the urgency of medication initiation, with high-risk patients starting therapy within weeks after surgery. If it is determined that a patient needs medication after surgery, the timing of when to start the medication is up to the gastroenterologist and the surgeon, and often depends on how quickly the surgical wound heals and whether it has any signs of infection. As a general rule, your gastroenterologist and surgeon will want to start therapy soon after surgery, but not until your wound is well healed and free of infection. In patients who do not start medications shortly after surgery, IBD doctors will generally perform an endoscopy approximately 6 to 12 months after the surgery to see how much inflammation is present. The decision about when to scope after surgery can be assisted by regular monitoring of fecal calprotectin every 3 months after surgery. After complete resection of the inflamed intestine, the fecal calprotectin should be less than 100 micrograms per gram of stool. When the fecal calprotectin rises above 100, there is a high probability of recurrent ulceration just upstream of the anastomosis, where the intestine was reattached. Your doctor may use fecal calprotectin monitoring to decide to do endoscopy earlier or later after surgery. Decisions about initiation or escalation of medications are then made based on the endoscopy results. More inflammation makes the initiation of anti-inflammatory medication a more urgent issue. It is important to limit postoperative recurrence of Crohn's disease to improve a patient's quality of life, to limit long-term damage to the bowel, and to reduce the need for additional surgeries. With multiple intestinal resections, patients can be at risk for the development of short bowel syndrome, in which there is insufficient small intestine left to absorb nutrients, which can lead to symptoms such as diarrhea, significant malabsorption, weight loss, and nutrient deficiencies. Many people with short bowel syndrome will require intravenous calorie supplementation, TPN or total parenteral nutrition, or medical therapy to increase the absorptive surface area of the gut with medications like teduglutide or Gattex. I'm Kelly Cushing. Thank you for watching IBD School 227.